Hi, welcome to the Injury and Violence Prevention video lecture series. Today's topic is health behavior and health education, examples from injury prevention. This is part of a series of lectures developed through a collaboration between SAVIR and Safe States Alliance as part of a larger CDC-funded initiative where we've invited experts in the field to provide information and examples that can be used in a variety of settings so that we can raise awareness about the field of injury and violence prevention among students, professors, and practice professionals, and familiarize all public health students with a basic understanding of injury and violence prevention. My name's Andrea Gielen. I'm a professor emerita at the Johns Hopkins Bloomberg School of Public Health, where I had the pleasure and privilege of directing the Johns Hopkins Center for Injury Research and Policy for a number of years. Today, I hope we'll be able to identify at least three examples of behaviors that reduce the risk of childhood injury, in particular, um, infant sleep deaths, and become skilled in building effective behavior change programs using the PRECEDE proceed planning framework. And have you be able to give three examples of intervention strategies that are effective in addressing predisposing, reinforcing, and enabling factors that influence behavior. Don't get hung up on the jargon. You'll know what those are soon enough if you don't already. If you're someone who's familiar with the PRECEDE proceed planning framework, this will be a bit of a review, but an update because a new version came out just a couple of years ago in a fifth edition of the textbook, and I'll be using the newer model. We're addressing some SEEF criteria that include assessing populations' needs and assets, applying awareness of cultural values and practices to designing programs and policies, designing a population-based policy program or intervention, and to select communication strategies for different audiences and sectors. So let's imagine you've just been hired in your local health department, and your first assignment is to reduce the county's rate of childhood injury. You've gotten the health problem and you got to solve it. You may feel lost in the maze of the options that you have, but if you're like many people, you may start over here with putting together what you think is the best darn program with lots of good ideas, lots of hard workers, lots of handouts, lots of videos, lots of money, and lots of time, and solve the problem or not. Because what happens in that black box is a big question mark. If you start over here building the best darn program, you may not have any knowledge about why it worked, or if it didn't work, why the program didn't work. So, what Precede Proceed is all about is trying to fill in that black box so that what you build in your best darn program is something that is strategically connected to what you think has to change in order to get the problem solved. So, the first thing you have to do is figure out what has to be changed. So we think of Precede Proceed as a roadmap to success. It was a model that was first created in the late 1970s, and it's been widely used nationally and internationally to address numerous health issues, and it's now in its fifth edition. So here it is, lots of boxes and arrows. But let's start over here at the left, where I started talking about the best darn program that we all want to build. You have a program that consists of interventions, strategies that you implement, and then evaluate. And those have to have some causal relationship to what you want to have your outcomes being. And those outcomes are on the right hand side. They have to do with quality of life, health status. And then what determines health status is multifaceted. It includes genetics, behavior, the environment. And if you're setting out to modify behavior as a component of a health problem, you need to understand what motivates behavior. And we classify those things as predisposing, reinforcing, and enabling. And we'll talk about them in more detail quickly. Um, And you need to think about the environment or the context in which the behavior and the health problem occur. So, by working from right to left instead of left to right, you're going to start by assessing the social dimensions, the epidemiological dimensions, the educational and ecological dimensions of the problem. And putting all that together, you'll be ready to build the best program and policy that you can to support more healthy outcomes. So let's look at an example. The example is sudden unexpected infant deaths in the United States. There are over 3,000 every year. That's about 100 per 100,000 live births in 2022. And SUIDs actually are made up of three different diagnoses or conclusions. The first one is that the infant died by accidental suffocation and strangulation in bed, or ASSB, which is often due to soft bedding. A person overlays on the infant because they're co-sleeping, or the infant gets wedged in a soft surface or in a soft crib bumper. The second category is SIDS, which we're all much more familiar with, but SIDS, sudden infant death syndrome, is actually unexplained through investigation. So the baby's death remains unexplained after a thorough investigation. And then the third category is unknown, when even after investigation, or they weren't able to do an investigation, the underlying cause is unknown. So the breakdown of those 3,700 deaths look like this. The 41% are sudden infant death syndromes, and the ASSB in the green is 28%, and the unknown causes are 31%. So we had an opportunity to address this problem in the Safe Start project, which was funded by NICHD at the National Institutes of Health and was a collaboration between our injury center and the Department of Pediatrics, where they care for many newborns and children in the Harriet Lane Clinic. And at the time of the study in Baltimore City, where we're located, infant mortality rates hit an all-time high, including those due to unsafe sleep practices. And in response, the Baltimore City Health Department initiated a citywide Be More for Healthy Babies initiative that included a wide swath of efforts, including mass media, community outreach, giving away free pack and plays or portable cribs, and education for providers and patients. And in hospitals that participated, they created and showed a video that showed three Baltimore families who had each lost an infant due to unsafe sleep practices. We also learned that 90% of the infants who died from sleep related deaths between 2009 and 2015 were African Americans, while African Americans make up only 63% of births in the city. So has a disproportionate impact on that population, which is a group that is widely served in the Harriet Lane Clinic. So, what did we do? We created the Safe Start, Safe Sleep for Baby program for the Harriet Lane Clinic. And over here on the left, you can see the program components included a health educator, counseling, pediatrician guidance, and a free safe sleep product. We then included monitoring the implementation, tracking the distribution of safety products, and a randomized control trial to evaluate it. Now, what we expected to have as our outcomes were the safety behaviors: the baby sleeps alone on its back in a crib, and there's no smoking, or as we commonly call it now, the ABCs of infant safe sleep. And the environmental factor that we were concerned about was the expense of cribs, the healthcare system inconsistencies in making recommendations or facilitating access to cribs, and the crowded living conditions of the clients we served. So, if we could address those behaviors and those environmental barriers, we could see, we hoped, a decrease in SIDS and ASSB. so that families and their children could live to their full potential and avoid the pain and suffering associated with an infant sleep death. So, what you see on this chart is the black box in the middle. I'm going to show you the interventions, and then we're going to talk about why we use those specific interventions. The health educator counseling was one on one, patient centered, and interactive education on safe sleep provided by a health educator. And you can see here the health educator is using a flip chart to talk with a mother and her baby. The flip chart showed a picture, I showed many things, but this is an example from it, a picture that explained how the baby's anatomy keeps him safer on his back. And that is to explain the rationale for the recommendations and to begin a discussion of exploring the barriers to following them. Now, this part, I don't expect you to be able to read it all, but I wanted to show you this was the curriculum that the health educator used so that the health educator used this information to communicate in a straightforward conversational way, the information that was shown on a series of flip charts with the client. So in addition, the health educator counseling included supplementary messages that were in literacy friendly take home print materials. These were written at the sixth grade reading level, and we produced them except for the one that we got from the Consumer Product Safety Commission, which met our criteria for literacy friendly and appropriate to use, and the tobacco quitline material, which we just from our health department, which we reproduced on materials to match our formatting. And these were all pre-tested, which is one thing I will note is critically important, that you need to um, pilot test your materials, which will be easier to do if you're working with members of your population in designing the program through every step of the process, which is something that is always recommended also. Then the pediatric guidance, we met with the staff of the Harriet Lane Clinic to talk about the program. We met with the social work staff to coordinate how we were going to distribute the pack and plays if clients couldn't get them from the Be More for Healthy Babies campaign because they were often oversubscribed. How were we going to get the pack and plays to them? And then to explain what our messages were so that the social worker could reinforce those in their conversation with the clients. And then we developed an online training module for the pediatric residents. This was a residency training clinic we were in that included information on safe sleep. And their preceptors reinforced that they should talk to their patients about infant safe sleep, and they were all required to complete the online module on the topic. And then we distributed the free pack and plays. And I should point out here, this is the health educator instructing the parent in how to use the pack and play. And I should point out that it's important to have a teach back component, which is what she's demonstrating here, is teaching the patient how to do something and then have them show you that they understand the information. So why those interventions specifically? Well, because we wanted to address predisposing, reinforcing, and enabling factors that you see here in what had previously been our black box with question marks. Um, so predisposing factors are knowledge, attitudes, and beliefs that motivate a person, inspire a person to want to take action, the action that you are recommending. So here, through some formative research that we had done that I don't have time to go into in detail, we could identify that parents did not have knowledge of why the ABCs of safe sleep were recommended. They didn't think that they were a particular risk. They had been influenced by earlier children or by their parents. the grandparents of the babies. And they had beliefs about the barriers of doing it, that the baby wouldn't sleep well that way, et cetera. So we wanted to address those particular predisposing factors. Then reinforcing factors are the things that people who are important to you, when they explain something to you or when they support you in doing something, you're more likely to keep doing that behavior. And in this case, the pediatricians were our reinforcing factors, our social influence, social support person. So they needed to have systematic guidance that they provided to their parents about sleeping alone, back, crib, no smoking, which is what we developed in the online module and which the residents preceptors talked to them about. And then the enabling factors are like the third very important component that's often forgotten. If people know what to do, they want to do what you're suggesting they do. People who are important to them are encouraging them to do it. If they have real world constraints, like having to buy a crib or um, that kind of expensive product, they're not going to be able to do what you're recommending. So, distribution of the free safety products was very important. And then to provide new skills that people need to have confidence in their ability to do what you're asking them to do. So that was the rationale for why we built the program the way we built it. And then in terms of our evaluation, we did a randomized trial of the intervention with the pediatricians and the health educator versus the standard of care, which was standard pediatrician guidance. Um, the intervention visit at 2 weeks of age and two home visit follow-ups were used to measure observed and self-reported outcomes in a sample of 106 new moms who were on average 25 years old, 43% first-time moms, 93% African American, 86% on medical assistance, and 61% with high school or better education. So here you see we looked at any clutter in any sleep product in the home by the intervention group and the standard care group. And what we saw was the that in the standard care group, we saw clutter in one or more of the sleep products in 63% of the cases. Whereas in the intervention group, we saw clutter in only 31%. So that was a significant improvement in the intervention group, although I will say we still have work to do. We would rather not see clutter in any of the sleep products. And I also want to point out that in two homes, there were still crib bumpers, which had been banned for sale in Maryland since 2013. So it's important to point out that if you're doing any kind of work that involves products, it's important to remember that one, people often use hand-me-down products, and two, products can get recalled or no longer be considered safe. So when we looked at cribs, in addition to looking for clutter, we also had to look at the age of the crib and whether it was live up to current standards from the Consumer Product Safety Commission. So just something else to keep in mind if you're working with any products. Here we see the self-report at 1 month by daytime sleep and nighttime sleep, comparing the intervention and standard care group. And on the left, we have alone, sleeping with no people, alone, sleeping with no objects, on the back, in a crib, pack and play or bassinet, and then tallied all safe. And if we look at the bottom row, we can see that the daytime sleep, 72% of the intervention group reported all safe sleep, compared to 52%, which was significantly different. And similarly, at nighttime sleep, 94% of the intervention group versus 63% of the standard care group reported all safe sleeping behaviors. Again, significant differences. Whoops. So let me wrap up by saying that Precede Proceed helps build successful health behavior change programs for injury and many other public health problems because it helps the planner go beyond just information sharing. It helps you understand that behavior occurs within environments that make it easier or harder to act safely or healthfully. It addresses individuals and their environments, and it makes the safer or healthier behaviors easier, or the default behaviors is what we try to achieve. So if you're wondering what the acronym stands for, here you have it. But what I like to do is remember that you have to precede before you proceed. You have to go through the assessments, understand your audience, the data, and the evidence for what you're going to recommend, and then build the program. So you work the model from right to left to build your program, and you follow the arrows from left to right to implement it and show how it works, or in places it doesn't work, at least you know what you need to improve next time. If you're interested in more details on the assessment, planning, and implementation process, there is a longer version of this lecture in this series, which I would recommend that you look at. And also, the textbook does a really good job of going through all of it in great detail. So let me leave you with Ben Franklin. Failing to plan is planning to fail. So, as your roadmap to success, Precede Proceed is a planning tool that we believe can help prevent plan failure. So, thank you very much for participating in this. Some assessment activities based on this very brief introduction is, I think you can list 3 causes of sudden unexpected infant deaths. Identify one type of intervention strategy for addressing each of the predisposing, reinforcing, and enabling factors. And then think about how you might use behavior change interventions in your work. Here are our references. And for more information on these 2 great organizations, just scan these. And I wish you all the best in your career in public health, one of the best careers there is. Thank you.